I want to introduce Dr. Jason Bonomo. He is a board-certified cardiologist, certified in general cardiovascular disease, echocardiography, and internal medicine. He joined Inova in 2022 and has been practicing since 2016. Prior to joining Inova, Dr. Bonomo completed his cardiovascular fellowship at Northwestern University School of Medicine at Northwestern Memorial Hospital in Chicago. During his fellowship, he gained extensive knowledge and expertise in diagnosing and managing complex cardiovascular conditions. Dr. Bonomo has a strong passion for research and a drive to understand the genetic components of various diseases. He pursued a PhD in molecular medicine and translational science. His research focused on investigating the genetic factors contributing to the development and progression of complex diseases, including hypertension, diabetes, kidney disease, and heart disease. Dr. Bonomo sees patients at the Inova cardiology offices in Boston and Fairfax, and he's on the medical staff at Inova Fairfax and Fair Oaks hospitals. Dr. Bonomo, the floor is now yours. We look forward to your talk, and I will be back at the end to pass along questions. Thanks.
Thank you, Dr. Levy, and thank you for everyone for joining us. Let me get this started. So thank you, everyone, for being here for today's talk. My name is Jason Bonomo. We'll be talking about type 2 diabetes and cardiovascular disease. It's a very, very broad subject, but what we'll kind of do is have an introduction and then more or less a guide what we can do to help, one, prevent diabetes, and then two, if we do have diabetes, the things that we can be doing to mitigate our excess risk of things like heart disease and cardiovascular disease that come along with having type 2 diabetes. And so I have no relevant financial disclosures. This is the outline that we'll be following today. We'll be going over, what is type 2 diabetes? How do you diagnose it? How does it affect cardiovascular health? How do we prevent type 2 diabetes to begin with? How do we prevent patients with type 2 diabetes from developing cardiovascular disease? And then finally, we'll get into a very brief summary. And so at its very heart, type 2 diabetes is essentially an inability of the body to properly manage blood glucose. It's commonly referred to as blood sugar. When we refer to the blood sugar, generally we are referring to glucose. And it's the levels of glucose go hand in hand with something called insulin. Insulin is a hormone secreted by the pancreas that helps the body absorb and use the glucose for metabolism so that the cells in our body have the energy to produce and do the things that they need to do. Type 2 diabetes is characterized by high levels of blood glucose as well as insulin resistance and an impairment in the body's ability to secrete insulin. What this leads to over time is higher levels of blood sugar or blood glucose that essentially impacts every single organ system in the body. And that's because high levels of blood glucose are toxic to cells and also the blood vessels that's carrying that supply of nutrients in the blood to those organ systems and cells. And this is just a little schematic of, what a normal blood vessel would look like in terms of, the red blood cells that are there and the amount of glucose. And then in diabetic patients, they just tend to have a lot of extra glucose. So what happens when we eat something? What should our body be doing after we eat a meal? In this case, in this picture, an apple. So we're eating an apple, the food, we start to actually digest the food when it's in our mouth, moves from our mouth to our esophagus and our stomach. And then when it's there, the pancreas starts to wake up. It's sensing that there's food, that there's glucose, and that the body is going to have a meal. And that because of that, the pancreas starts secreting insulin. Insulin helps bring glucose into the cells so that the cells can use the glucose for fuel. It helps prevent, higher levels of blood sugar. But with type 2 diabetes, what happens, is that generally the pancreas stops working so well. The body becomes more resistant to insulin. And so over time, you have these higher and higher levels of blood glucose circulating around in the blood. that's causing what we call high levels of blood sugar to all parts of the body. Who has type 2 diabetes? It's roughly 38 million Americans, about 1 in 10 people. And of those 1 in 10, about 1 in 5 don't actually know that they have type 2 diabetes. When we look at the incidence of diabetes over the past 20 years, it's actually been increasing quite dramatically. Why type 2 diabetes matters so much to me as a cardiologist is it's can be very fatal. The statistics are about 80% of patients with type 2 diabetes will actually pass away from cardiovascular disease. And so for me, it's really important to be aggressive when a patient has type 2 diabetes so that we prevent heart disease from developing, progressing, so that patients can live a long, healthy life. This is a map of the prevalence of obesity and diabetes in the United States about 20 years ago in 2004. The lighter colors show lower rates. So the lighter blues are lower rates of obesity. The lighter orange to red are lower rates of diabetes. The more purple colors are where diabetes and obesity kind of mix together to have higher levels. From 2004 to 2009, we see a pretty significant increase in the amount of diabetes pretty much across the country. The most recent set of data looks even worse, and this is about 5 years ago. Some areas of our country just high levels of type 2 diabetes, high levels of obesity. If we look to see where our local area in Northern Virginia, we're actually doing really, really, really well compared to other parts of the country. Certainly around Northern Virginia, there are areas, where there's still a lot of, both diabetes and type 2 diabetes. And even within Northern Virginia, there are some issues related to access to care. Not everyone may be getting the best care that they need in the treatment and management of their diabetes. And so, but on the whole, Northern Virginia is doing pretty well. What's one of the most alarming trends for me as a cardiologist is that we're seeing type 2 diabetes now in a patient population that we did not used to see this in, several decades ago. And that's in children and youths aged 10 to 19, where we're actually starting to see not type 1 diabetes, which is an autoimmune disease, but type 2 diabetes, which is a metabolic disease in young children, which is particularly worrisome. When we look at the risk factors for type 2 diabetes, and we're going to be exploring these throughout the talk, by and far one of the largest risk factors is obesity. And it's not just where the extra weight is, it's the distribution of where that extra weight is. And so we call that central adiposity, or particularly, patients that have, larger bellies, larger abdomens, larger waist circumferences. So those patients are going to be at much greater risk of developing diabetes. And about 90% of patients with diabetes have obesity. Physical inactivity is also another risk factor. Genetics and family history are also important. Genetics contributes about 10 to 20% of the risk of type 2 diabetes. So it's part of the story, but it's not quite the whole story. Race and ethnicity, for a number of reasons, also play a role. And so people with African descent, Hispanic descent, Asian descent, Native Americans, and Pacific Islanders are much more likely to develop type 2 diabetes compared to those folks with European ancestry. Age is another important factor as well. And so, generally when we, think about type 2 diabetes, it's in patients over the age of 35. But like we mentioned earlier, we are starting seeing type 2 diabetes in adolescents. One of the biggest risk factors that's actually incredibly modifiable is prediabetes. And that's something that we will touch on later in the talk too. And then risk factors unique for women. If you have polycystic ovary syndrome or PCOS, that's a risk factor for type 2 diabetes. If a woman developed gestational diabetes when they were pregnant, that also confers a greater risk of type 2 diabetes. So, how do we diagnose type 2 diabetes? We do it through two mechanisms. One is we just check the blood sugar level or the blood glucose. And another way we can check it is check something called the hemoglobin A1C. What is hemoglobin A1C? It's basically the amount of glucose or that sugar that sticks to the outside of the cell of a red blood cell expressed as a percentage. And what this does is it's reflective of the past 2 to 3 months of glycemic control. So it tells us not just how has the diabetes been today, yesterday, the past couple weeks, but how has the diabetes been treated over the past 2 or 3 months. And so if you have, say an A1C of 10%, which is quite high, 10% of the outside of the red blood cell is essentially covered in sugar. Ideally, we would all be here, which is normal with an A1C, so under 5.7%, and our fasting blood sugar would be under 99. When we start to get concerned or when I should say, when I start to get concerned, it's when I see a patient with prediabetes. That is a hemoglobin A1C between 5.6 and 6.4 with an elevated blood glucose level. It's not quite diabetes, which is an A1C of over 6.5. Anytime you have an A1C of over 6.5, clinically, excuse me, one has type 2 diabetes. When I think of type 2 diabetes, I think of it as a disease of blood vessels. In our bodies, we have a ton of blood vessels. We have really big blood vessels, we have medium-sized blood vessels, we have small blood vessels, and we have really minuscule, tiny blood vessels. And our blood vessels in our body, they're vital for healthy organ function, for all the other parts of our body. And when we think of diabetes, we know a lot of other organ systems are involved. Because the eyes have a blood supply, right? You are at risk of developing things like cataracts, glaucoma, diabetic retinopathy. You can get kidney disease from diabetes. You can get nerve disease. We'll be spending a fair portion of the talk today talking about heart disease. There's also other types of vascular disease of, the larger arteries in our arms and legs. It can contribute to certain types of neurological diseases. It can impede wound healing. So patients with diabetes have a longer time. It takes them a longer time for wounds to heal. And then they're also at increased risk of certain types of skin and soft tissue infections. Okay. And when we think of type 2 diabetes and the cardiovascular system, patients with type 2 diabetes are almost twice as likely to develop heart disease compared to those without diabetes. Patients with type 2 diabetes are 2 to 4 times more likely to have a heart attack, 1.5 to 3 times more likely to have a stroke. They have an increased risk of heart failure. They have increased risk of peripheral vascular disease. That's generally narrowing of the arteries in either, the limbs. They have higher rates of high blood pressure. And then they also have, what we call microvascular disease of different blood vessels or disease of those really, really small blood vessels that can impact the brain, the eyes, heart, and nerves. The heart's a pretty simple organ. Arguably, it really does three things. It pumps blood to itself. It pumps blood to the rest of the body via arteries. And then that blood gets recirculated to the heart through veins. And then it also conducts electricity. And diabetes can affect each one of these functions of the heart, and we will explore those. When we think about the heart and the blood supply to the heart, this is something that I generated or AI generated with some prompts, but it's essentially, we're looking at a heart muscle. This is the aorta, the big blood vessel coming off the heart. But you see these arteries on the outside of the heart, and these are what we call the epicardial heart arteries. And you see these tiny, tiny blood vessels, kind of like they look almost fuzzy. That's called the microvascular system. And so, we have the main blood arteries of the heart that we can see, that we can intervene on, that we can put stents in. But there's so much more to the heart than just these big blood vessels on the outside of the heart. There's this whole intricate network of tiny, tiny, tiny little blood vessels within the heart that we can't see, that are needed. Healthy blood vessels are needed for proper function of the heart. When we take pictures of patients' hearts with an angiogram, for example, you can see, we can really only see those big blood vessels on the outside. We can't see those tiny little blood vessels that really supply most of the blood to the heart and the heart muscle. And diabetes can affect both the big blood vessels in the heart as well as the smaller blood vessels in the heart. One of the main manifestations of type 2 diabetes is what's called coronary artery disease, which is narrowing of an artery in the heart. Patients with type 2 diabetes, like we said, are about 2 to 4 times more likely to suffer a heart attack. What does that look like? Well, this is a blockage in a blood vessel called the left anterior descending artery. Generally when that happens, we can put in a stent and fix the blockage. How does type 2 diabetes kind of accelerate that process? So that's a really, really complicated question, complicated answer. Try to simplify it, but essentially that process of heart disease starts when we're really young, in our late teens, early 20s, and then over time, you start to get these cholesterol deposits that grow and grow and grow. Eventually, you get a little bit of calcium on the outside. And then the plaque either, ruptures and causes a problem, or, a problem like a heart attack, or it kind of stays put. But what diabetes essentially does is, through higher levels of blood sugar, it causes more stress on the heart blood vessels. And it really accelerates the rate at which this process called atherosclerosis, or plaque formation, occurs. We were talking about how diabetes affects the larger blood vessels in the heart. Diabetes can also affect the smaller blood vessels in the heart. This is called microvascular coronary disease. What this looks like is reflected in this diagram here, where you have a healthy heart without diabetes, good blood flow, good function of the lining of the blood vessels. When a blood vessel has too much sugar in it, that causes damage to the blood vessel. It causes stress to the blood vessel, causes the blood vessel to die. And that can manifest in a lot of different ways. For example, with microvascular disease, it can impair the heart's ability to relax. So the pump function of the heart is just as important as the heart's ability to relax. So if the heart can't relax, you can develop something called heart failure. Other problems that we run into with diabetes and the microvascular system relate to increased inflammation, increased stiffness of the blood vessels, and abnormal regulation of the linings of those tiny capillaries in the heart. Type 2 diabetes can also cause heart pump problems or heart failure. Patients with type 2 diabetes are at a 74% increased risk of developing heart failure. Up to 25% of patients with type 2 diabetes will develop what's called chronic heart failure, or live with heart failure the rest of their life. And about 40% of patients admitted to hospitals for acute heart failure have type 2 diabetes. What does heart failure look like? So this is what a normal healthy heart is doing. You have the blue blood is the venous blood, the red blood is the oxygenated blood, and the heart's, pumping blood to the rest of the body. What happens in heart failure is the heart muscle is weakened. The left ventricle, or sometimes the right ventricle, sometimes both ventricles, they don't pump as well. And so that leads to problems with fluid retention, buildup of fluid in the lungs, in the belly, in the legs, people not breathing well, pretty serious complications. The third kind of way the heart works is that it has a conduction system or an electrical system. And type 2 diabetes can affect this too. You might have heard of something called atrial fibrillation. Atrial fibrillation is an abnormal heart rhythm that causes the top chambers of the heart to beat very, very fast and out of sync with the bottom chambers of the heart. When the heart's beating out of sync, blood stagnates in the top chambers of the heart, clots form, and atrial fibrillation predisposes patients to strokes. If you have diabetes, you have about a 40% increased risk of developing atrial fibrillation down the line. And about 3% of patients with diabetes each year will develop atrial fibrillation. It can cause other types of electrical problems in the heart. It can cause what's called heart block. Heart block requires a pacemaker. And it can also cause other sorts of conduction disease and also what's called autonomic dysfunction. I think the biggest takeaway is preventing type 2 diabetes and the things that we can do to prevent one from actually developing diabetes in the first place. In order to do so, we kind of have to get a sense of the company that diabetes tends to keep. Usually the patients that are at risk of developing type 2 diabetes have what's called metabolic syndrome. This is a clinical syndrome of generally high cholesterol, high blood sugar, high triglycerides, high blood pressure, and then also obesity. And metabolic syndrome is just a setup for developing type 2 diabetes. About 1 in 3 patients in the United States has metabolic syndrome, and about 85% of patients with diabetes have metabolic syndrome. So how, if we have some of these things, but we don't have diabetes just yet, what can we do to kind of change the trajectory of our body to prevent these things from happening? We should all be seeing our regular primary care physician once a year. And what your primary care doctor is going to do almost always is check your hemoglobin A1C to see, do you have type 2 diabetes? I always get alarmed when I see a patient with prediabetes, because for me, that's the time to act. I don't want to wait until a patient has diabetes. If a patient has prediabetes, I want to treat it, nip it in the bud, so that they don't develop diabetes, so that they don't have to live with all the extra cardiovascular risks and even the non-cardiovascular risks, the eye disease, the kidney disease associated with diabetes. So really, I think this is where we need to target. And so what do we do? The biggest thing that we can do is, one, take care of ourselves, treat our body like a temple. We want to have a healthy diet. Generally the Mediterranean diet is what we recommend in cardiology. It's a diet that's high in fresh fruits and vegetables, lean proteins like fish and poultry, olive oil, nuts, almonds, whole grains, and really limiting processed food, limiting takeout foods, the types of foods that promote insulin resistance, that promote weight gain, that promote high blood pressure. Other things we can do are, stay active. It's recommended that all Americans, not just Americans, everyone, gets in about 150 minutes of moderate intensity exercise per week. What that is, brisk walking, jogging, running. Anything is better than nothing. You also want to avoid prolonged episodes of sitting for more than 30 minutes at a time. If you can, and if this kind of fits you, right? Not everyone with type 2 diabetes will be overweight. Most are, but weight loss will help. So if you're overweight, maybe in that pre-diabetes range, one of the best things that you can do to prevent the development of diabetes is, getting back into shape, or not into shape, but, maybe just losing a little bit of weight. And that's also going to help lower your blood pressure. It's going to lower your risk of heart disease, and it's also going to lower your risk of stroke. So say you have type 2 diabetes and you're worried about your heart health. There's still a lot that can be done to prevent the kind of complications that we talked about, heart failure, heart artery disease, atrial fibrillation, and other electrical problems with the heart. Exercise, weight management, and a healthy diet, that's always going to be a cornerstone of, any physician's recommendation for type 2 diabetes. If someone's A1C, is above, maybe 7.5, this isn't going to be enough. You're going to need a little extra help to get you there, like diabetes medications. Other things you can do, if you smoke, quit smoking. Smoking is, one, increases risk of heart disease. If you add smoking to, diabetes, that's really just a setup for both heart disease and stroke. Stress management is important. When we're stressed, our body releases a hormone called cortisol. Cortisol increases our blood sugar levels, and it can feed a vicious cycle. This is something I run into pretty often, but statins, which are cholesterol medication, they are a cornerstone of therapy for patients with type 2 diabetes. We'll talk about them extensively on the next slide, but if you look at the recommendations by the American College of Cardiology and also the Endocrine Society, it is very highly recommended that every patient with diabetes, even if their cholesterol is normal, that they should be on a cholesterol medication. Some of my patients that have type 2 diabetes are on aspirin. Generally, this is case by case, but because there are some risks associated with aspirin therapy. And then we can do things like screening for heart disease for, patients with type 2 diabetes. But I'd like to spend a little bit more time talking about statins just because in my experience, I found that these are some of the most misunderstood medications. They do a lot of things. So they're known for lowering cholesterol, yes, but they do a whole host of other things aside from that. They help stabilize the plaque in the heart arteries, preventing that plaque from rupturing and causing a heart attack. They have anti-inflammatory properties. We were talking about earlier about how diabetes is a disease of the blood vessel and that glucose just damages the blood vessels over time. Statins prevent damage to the blood vessels. They also lower your cholesterol, which is really important. If you have type 2 diabetes, you want your LDL cholesterol to be under 70 or under 55 if you've had a prior heart attack or stroke. There are other types of cholesterols out there. One is called LP little a or lipoprotein A. If yours is elevated, what I do is treat to a lower LDL goal because we know that this particular type of cholesterol, is about 6 times more what we call atherogenic or plaque forming than the LDL cholesterol. And in this little schematic, you kind of see a summarized version of what we discussed here. This is, I can't say this enough. The most common side effect for statins is no side effect. I get asked this all the time. I started taking a statin, I developed muscle aches the next day. Muscle aches with statins generally don't develop for a couple weeks or months after using them. Again, very well tolerated, very, very well studied. They're all generic. They're just great medications. When we talk about screening, there are different types of screening tests that we can do for patients with type 2 diabetes to kind of help risk stratify where they are. The simplest one is an EKG, which is shown here. An EKG is a 10-second strip of the electrical conduction system of the heart. What I tell my patients is that, EKGs, they're not perfect. They were invented in 1895. By and large, we're still doing them the same way, 100 plus years later. But they tell us a lot of good information about the heart. And, if your EKG is abnormal, that might prompt something like an echo or an ultrasound. to look at the heart pump function. Are the heart valves working well? Another measure that we can do to help kind of risk stratify patients with type 2 diabetes to prevent heart disease is their coronary artery, is checking what their coronary artery calcium score is. Like we talked about in other slides, plaque formation or atherosclerosis takes a really, really long time, but diabetes accelerates this. Calcium is one of the end products of that formation of that plaque in the heart arteries. We have tests out there that can detect that heart and quantify to what extent does a patient have heart artery disease using coronary calcium as a surrogate. In here, in this picture from the Cleveland Clinic, you see, a heart with no calcium, no brightness, and the calcium score of 1. That would suggest that their risk is minimal. Contrast that with someone whose calcium score is 1200, and you see all this bright white here and here, and that's just the heart blood vessels that are actually calcified or partially calcified. Okay, and so the take-home points that I'd like you guys to kind of take home with you is that diabetes is increasing in frequency in the United States and is associated with worse cardiovascular outcomes, from heart attack to stroke, and so forth. And it's a disease of blood vessels that affects the entire body. It's preventable, right? Type 2 diabetes is preventable. If we exercise, if we eat healthy, if you talk to your doctor and see your doctor regularly, you can very easily prevent diabetes from developing. My personal opinion is that we need to be more aggressive in patients with prediabetes. There's no data out there yet that shows that patients with prediabetes have higher rates of stroke. There's no data that shows that they have higher rates of coronary artery disease. There's no data that shows that they have increased rates of kidney disease. So if we can nick prediabetes kind of in the butt before it becomes diabetes, why not? All of those who have type 2 diabetes should be on a statin medication to reduce the cardiovascular complications. And like we talked about, statins do a lot more than just lower cholesterol. They're safe, effective, very well studied. Heart disease and stroke are preventable in patients with type 2 diabetes. So talk to your doctor. That's what I would recommend. Thank you so much. This office phone number is our Fairfax location, and I will hand it over to Dr. Levy for any questions.
Wow, that was awesome. Whoa, you almost disappeared there for a second. That was really awesome, and we have a lot of good questions. And you covered a lot of ground. I'm going to ask you, hey, should diabetics take statins? No, I just want to hear you say it again because it's just so critically important. No, but the question I think we both get asked is, well, my cholesterol is normal. My LDL is 95. I'm a diabetic. You're telling me to take a medicine that's going to reduce. Why should I take a statin if my cholesterol is normal? Does that matter?
Absolutely, absolutely, that matters. And like we talked about, it's not just the cholesterol that the statin's doing. It's protecting the lining of the blood vessels on the inside of the whole entire circulatory system. It's an anti-inflammatory. It's reducing all that damage that's occurring in that really high blood sugar milieu caused by type 2 diabetes. And by bringing down that LDL cholesterol, you're going to get some benefits to that. But every patient with type 2 diabetes should be on a statin. And if you're not on one, ask your doctor about it.
Well, if everyone just takes that home tonight, I think that's important. Someone asked, are statins dangerous for your kidneys? If you have some mild kidney disease, you have some chronic kidney disease, is it okay to take statins?
That's a fantastic question. So there's one statin in particular, or several statins in particular, where we have to lower the dose of the statin or the patient's kidney. Rosuvastatin or Crestor comes to mind for me, but still you can be on another what's called high intensity statin medication called atorvastatin that doesn't interfere with the kidneys. So absolutely. And what I would say is If you have kidney disease and diabetes, or even just kidney disease, that's a very potent risk enhancing factor for metabolic syndrome and cardiovascular disease. So even more of a reason to be on a statin.
Yeah, I'm going to throw a couple of my own questions in here for a minute. There's a couple of, I don't want to get into medications that are purely for diabetes. That's our endocrinologists and diabetologists can manage those. But how about some of the newer medicines that are a crossover, that are for diabetics and have been shown to reduce the likelihood of cardiovascular disease, like the SGLT2s, and then maybe we can touch upon the GLP-1s, some of this, like the Ozempic kind of medication.
I think that's so fascinating, right? So you have these classes of medications that were developed years ago to treat diabetes. But then during clinical studies, for example, empagliflozin or Jardiance, which is an SGLT2 inhibitor, Farxiga or dapagliflozin, right, that in these clinical trials showed profound mortality benefits in terms of reducing risk of cardiovascular disease. I think that speaks to just the milieu of how the interaction between type 2 diabetes and cardiovascular disease and metabolic syndrome, how it's all so linked. And if you can hit, one pathway and have a multitude of effects in terms of prevention, I think that's fantastic. The data for GLP-1, things like Ozempic, semaglutide, it's coming. We're seeing that, we're seeing a mortality benefit in some patients. I think the trial was BMI of over 25, heart failure, and they had lower rates of hospitalization and lower rates of heart failure. And so what we're seeing is just the pleiotropic effects of these drugs extend beyond diabetes, and they are, some of them right now, SGLT2 inhibitors, a cornerstone of therapy for us as cardiologists. And I see, the semaglutide and analogs becoming also part of our arsenal, if not in the next few years, very shortly.
Yeah, that's great. Thank you for touching upon that. There were a couple of questions about coronary calcium, and I guess one of the questions was, well, is it the high sugar that causes the calcium deposits? And I think you sort of did this in your talk. You explained where the calcium comes from, but basically it's the diabetes that is facilitating the development of these plaques, which then calcify. And I think you touched upon that pretty well. I have another area that I think would be important to touch upon, and you talked about multiple organ systems being affected, but one of the things we do know about diabetics is that they have altered sensation to pain, right? They have to be really careful about, cutting their feet or wounds, because they won't necessarily have the pain that non-diabetics have. How does that relate to coronary disease and diabetics, and how we manage our diabetics with coronary disease, and when we should test diabetics versus non-diabetics? How's that?
That's such a fantastic, I'm glad you asked. Thank you so much. So for me, if I'm seeing a patient in the emergency department and I know they have type 2 diabetes and they have what I would say atypical types of chest pain, red flags still go off. If they, what I mean to say is, right, so when we think of heart disease and heart attacks, we classically think of chest pressure radiating to the arm, worse with exertion, better with rest. Only about a third of patients present that way. The vast majority of patients don't present that way. When you're diabetic, you can have silent heart attacks. I saw someone in the hospital, he was 43 recently. He didn't even know he had 2 prior heart attacks. Sometimes diabetic patients, their symptoms will be very, very, very atypical. Trouble breathing, throat, when they're walking, throat discomfort, any symptom at all that's new, unusual, not your normal, you should talk to your doctor about that.
Yeah, and I'll even add to that, diabetics with known coronary disease, I will test them more frequently. I won't necessarily wait for them to have symptoms, just because I'm so suspicious with diabetics, because we've both seen diabetics who've had silent heart attacks. They just didn't know. A couple of questions about once you have type 2 diabetes, do you always have type 2 diabetes? Can you cure it? Will you always need to be on medication?
That's a great question. I'm thinking back to my internal medicine days, and I remember we used to call it type 2 diabetes in remission. And so once you have it, you're always going to be at risk for having it again. Uh, I'm not an endocrinologist. My medical advice would probably be stay on your metformin. Just because your A1C is low doesn't mean if you take away that medicine that your A1C is going to stay low. It's one of those things that, for me at least, and I'm curious to see what your style is, but for me, once you have it, you kind of have it for life, but that's not to say you can't de-escalate some medical therapy.
Right. And, a lot of times associated with obesity, with weight loss, exercise. I think we've both seen lots of patients who've come off medication completely. They still need to watch their diet. They still need to do all the preventative things. But you can potentially get off medication. Um, Here's a good question. So I have type 2 diabetes. When should I see a cardiologist? Should all type 2 diabetics see a cardiologist? What do you think?
Slightly biased here, but have a conversation with your internal medicine doctor. Ask them, how's my cholesterol? How's my A1C? What risk factors do I have for heart disease? I will say some of my favorite visits are the prevention visits. The patients, just like you said, like I've had diabetes maybe 10, 15 years. I want to stay on top of my heart health. I think that's meeting a cardiologist in an office setting is probably a much better way to meet them than, in a hospital.
Sure. And a couple of questions, and it's probably worth mentioning. So you're diabetic and your doctor wanted you to start statins, and you are one of the very small percentage of patients who just really can't tolerate a statin. You just get terrible muscle aches in the large muscles, not those little muscles, but the large muscles in your legs and arms and shoulders. And you've tried 3 different statins. What's the alternative then?
Hey, it's a great day to be a diabetic with statin problems in 2024. We have a
Yeah.
number of non-statin medications that we can use that have mortality benefits. Those range from, well, the ones with the mortality benefits are injectable medications. Those you might have heard of them, Repatha or Praluent. They're PCSK9 inhibitors, much, much, much stronger than statins. They don't have those same kind of typical side effects, much more potent, and there's a mortality benefit. There's also a newer medication called bempedoic acid. Doesn't have the same side effects of statins, but it lowers your LDL cholesterol. And then there's a weaker cholesterol medicine called Zetia that helps inhibit absorption of the cholesterol from the GI tract. So if I had one of those patients who had type 2 diabetes, statin intolerant, I'd probably go, talk to them about something like Repatha or Praluent, just because the data is a little bit better for me in terms of mortality compared to bempedoic acid.
Yeah, I totally agree there. Quickly, is metformin a safe medication?
Yes.
Yes.
And
And
there's, I don't know how many of you guys are following the news, but a lot of people on the West Coast are using it as a medication to extend their life because there's some suggestion that it might extend your telomeres. But it's generally a very, very safe medication. Certainly all medications have side effects or potential side effects, but
here's a great question that I don't know the answer to, and you might, but you might not. If a woman is diabetic during pregnancy, does that increase the risk of diabetes in the infant or later in life? I guess there are 2 questions. Diabetes during pregnancy, and this is way off of the path of us as cardiologists, but we do know that it affects women. But does it increase the risk of diabetes in the child? I guess the question is focused more on family history.
yeah, I don't know if it affects the child's risk of diabetes exactly. I know if a woman is pregnant and they have type 2 diabetes, they're generally going to deliver a larger child. There are some complications that kind of go along that having, a larger child and delivering them, but I would have to get back to you about whether or not that child would have an increased risk of diabetes.
Right. I think we probably recommend that diabetic women who are pregnant should probably be seen by high risk, OBGYN physicians who manage the neonatal period there. Can people with cancer take a statin?
Absolutely. I think what's going on is that with a lot of our cancer treatments these days, cancer is becoming more and more of a chronic disease. And so, right, you have all these great immunotherapies that out there that help keep the cancer in check for years and years and years. And certainly, it can be very worthwhile to take a medication like a statin if, absolutely.
Oh, yeah. It's so funny. We both assume that everyone knows everything. Can you explain a little bit about, you talked about coronary calcium scores, you talked about coronary calcium, but you didn't really, I think, explain how do you get how do you measure a coronary calcium score? What's involved? Is that a very complicated, painful study, or is it something fairly simple? And then I'll even let you get on a soapbox, or I will, about why it's not paid for by insurance.
Yeah. It's a really quick, easy test. It's a CAT scan of the heart, so maybe about this much. The amount of radiation you get, it's about 3 hours of being in a plane in the sky, so not a whole lot of radiation. And it's basically just does a CAT scan of very low dose radiation of the heart arteries, and we quantify how much calcium is there with something called the Agrison score, and it's logarithmic, and the score goes from 0 to thousands, several thousand maybe. So a score of 1, 1 to 10, that's a 10 times jump. 10 to 100, another 10-fold jump. Very easy test. The problem with insurance is for whatever reason they don't seem to like to cover this, which is frustrating. They seem to think that it's an experimental test, even though it's been around for decades and decades and decades. And some of our finest data from cardiovascular disease has come out of trials using coronary calcium in those trials, but insurance companies still feel it's experimental. And so they like to decline it. The good thing is a lot of the hospitals in our area have this test for very, very, very low out-of-pocket cost, anywhere from $50 to maybe $175 to get it done if the insurance decides they don't want to pay for it.
Yeah. Something that I think a lot of patients don't understand, and it doesn't really matter, is that a lot of times if you have a moderately elevated coronary calcium score and you're put on a statin, your calcium score can actually go up because the statin has an effect on the coronary calcium that it just makes it like harder. But it doesn't mean that your disease is worse. It's not a direct correlation between that calcium that may change when you put on a statin and what it was before. Can diabetics donate blood? We're getting into sort of diabetes questions and not necessarily cardiovascular disease, but do you know the answer to that? Yeah, either do I, but I assume they can, but I don't know. So here, a lot of times when patients present with heart problems, they present with angina or a heart attack or any kind of a situation in which the heart hasn't gotten enough blood and oxygen, we often see their blood sugars go up. So does heart disease cause diabetes, or is it just a response to the physiologic stress that's going on when they're having a cardiac event?
I think that's a great question. I think a lot of times, anytime the body is under a lot of stress, your body's going to release stress hormones. A lot of the stress hormones, for example, cortisol, they're going to make your blood glucose levels go higher. So I wouldn't say that, having a heart attack, was the cause of high blood sugar, but maybe the inflammatory response, the stress response from the body was the cause for that. Certainly diabetes does, increase your risk of heart disease, and that's something, you want to be cognizant of. But I wouldn't say heart disease causes diabetes. No, I wouldn't say that.
Is there an easy way for folks to check? They go see their doctor for an annual visit once a year, hopefully, and they get maybe some blood tests. And, maybe they're told, well, your hemoglobin A1Cs, you're right at that borderline. You're almost pre-diabetic. Is there any way for them to check over the course of the year how they're doing without getting blood tests? Are there any home tests available that patients can do? Do you know?
So they're the glucometers that you can get at Walmart, Target, CVS. Sometimes they're about $20. It's pinprick, checks your blood sugar, and you want to refer to that chart that I showed from the CDC. Where if you're fasting, your blood sugar should be 99 or under, and then if it's over 200 and you're fasting, that's pretty suggestive of diabetes. Somewhere in the middle, you're still in that kind of warning zone where, you should be trying to work on diet, exercise, weight loss to bring down the blood sugar.
How about triglycerides? Are any of our cholesterol lowering medications very effective at lowering triglycerides?
Yeah, they're pretty effective. They're not purely meant to bring down triglycerides, but they tend to do so for the vast majority of patients. I was always, or one of the cardiologists that I work with, he always taught me that triglycerides were just sugar over sweat. So one of the best ways to get the triglycerides down, eat less sugar and sweat more. I still use that advice.
So, I'm really careful about not eating sugar. Is that enough to reduce my risk of developing diabetes?
I'd say probably not, because there's just, our diet is it's a start, but I'd have to know what else the person is eating. But I wouldn't just say just because you're not eating sweets and donuts, that's the classic things we think of with foods that have high sugar content, that doesn't necessarily mean you're not going to develop diabetes. I mean, I've seen patients, very petite women, eat incredibly healthy diets who have diabetes, right? There's still that genetic component.
That's really the bottom line. There is a genetic component, as you showed. There are racial differences, there are geographic differences that are tied to diet. Coffee. Anything you want to say about coffee, whether it's related to cardiovascular disease or diabetes or
It's last time I looked into this was a number of years ago, and there were a few studies that showed if you drink filtered coffee, that it's neutral, meaning the filter somehow absorbs some maybe of the oils that are in the coffee, and so it doesn't really affect your lipid profile or triglycerides. However, non-filtered coffee like espresso can sometimes adversely affect your lipids, not very much. I personally am fine with my patients drinking reasonable amounts of coffee, a cup of coffee a day, 2 cups of coffee a day, sure. 2-3 venti Starbucks, I think a little too much. But for me, most things in life, everything in moderation.
Yeah, all that caffeine will end up sending it to our electrophysiologist for their heart rhythm abnormalities. But hey, so if I'm taking cholesterol for other reasons, is it okay to take a statin as well?
Cholesterol, that's fenofibrate.
Yeah,
Yeah, absolutely, absolutely.
right. Let's see what else. Yeah, this is a tough question. This is a tough group. Jason, they're throwing you all kinds of curveballs, and a lot of these are outside of the cardiovascular domain. We're not endocrinologists, but do patients with celiac disease, are they more prone to diabetes and heart disease? Yeah, I'll ask you.
That's a great question. So celiac disease, right? So that's IgA mediated.
Mhm.
There's a little bit of an inflammatory component. I don't know if there's been any long-term studies looking at that question. You could posit that chronic inflammation of an autoimmune disease could cause increased risk, of cardiovascular disease. But if you take the gluten away and you're doing okay, maybe that mitigates the risk. But I'd have to do a PubMed search and get back to the
Yeah.
question writer.
Okay, last question, because I want to come back to this because I think it's important. Um, so I have type 2 diabetes, maybe borderline high blood pressure. Um, I'm not terribly active. Maybe I'm a little bit of a couch potato. I don't do a whole lot. I'm a little bit overweight, and I come to see you. And I'm 55 years old, and I have a family history of heart disease. What testing do you want to do with me that's going to make you feel comfortable that I don't have significant heart disease? And you have 45 seconds to answer the question.
Great. Hemoglobin A1C, standard lipid panel, apolipoprotein B, LP little a, coronary calcium study,
Coronary calcium. So
and
you're
an EKG.
right. And so you're using the coronary calcium as that initial first. If that's abnormal, then you're going to bring them back for some form of exercise testing to make sure they're not ischemic or something else. All
Yeah.
right. That's great. Dr. Bonomo, this was spectacular. We're just about out of time.